Now, how you approach a case of hypertension. The first step is accurate blood pressure measurement, which is office blood pressure, ambulatory blood pressure, and sometimes home blood pressure. And second, arranging for investigations regarding contributing factors, risk factors of cardiovascular disease, and regarding complications like target organ damage and comorbidity. How we approach hypertension, how we detect hypertension by measuring blood pressure. It is measured by sphygmomanometer. This is called office blood pressure. And we have ambulatory blood pressure. The patient carries the machine with him for 24 to 48 hours. And sometimes there is home or blood pressure monitoring. Anyway, the most important is the office blood pressure, sphygmomanometer, mercury sphygmomanometer. There are certain rules which we should follow in this. These are very, very important. Don't take it simply, because most our problem starts here. A patient checks his blood pressure in a clinic, he finds a number or a figure, in another clinic another number. These are mostly due to operator technique and not patient's fault. Occasionally the patient's sympathetic nervous system, but mostly it is operator's fault. The machine should be well validated and maintained, has maintenance, and properly calibrated. Then first, the position of the patient. Mostly it is sitting. It can be lying so that he will relax. Sitting, and then you should take a standing blood pressure in those who are elderly and diabetic to exclude postural hypotension. What technique? This is a technique. First, all tight clothing should be removed, except in exceptional case where the patient is embarrassed, etc. But remember, we are doing this to detect hypertension, not in hypotension or in the casualty department in a busy area. That's something else. The arm should be supported at the level of the heart. You should support the arm, and this should be at the level of the heart. And the sphygmomanometer should be at the level of the arm. And your eyes should be level of the sphygmomanometer. So there are 4 levels to advocate. The arm supported at the level of the heart. The sphygmomanometer should be at the level of the arm, and your eyes should be at the level of the sphygmomanometer, not looking from high, from up, or from down. These will give false or wrong figures. And obviously, you should have a clear area here. You should not push the head of the stethoscope under the cuff. You should palpate the radial artery and then put your stethoscope over it. And the cuff should be of appropriate size, but this area should be free. It should take the cuff 2/3 of the arm of the patient. And slow down the mercury slowly, not rapidly, 2 millimeters per second, as slow as you can. And read your blood pressure to the nearest 2 millimeters. The phase 5, which is disappearance of sound, is measure of diastolic blood pressure, not muffling, the disappearance. These are simple but very, very important. The other thing, you should take 2 measures at each visit, not single measure. You can't diagnose hypertension by single reading. Remember that hypertension is rise in arterial blood pressure, which is chronic. There is chronic elevation. So you need at least an average of 2 or more readings, blood pressure reading, during each of 2 more outpatient visits. Sometimes the visit might be 1 month. You can't tell from one visit, except when you have high blood pressure with target organ damage or a sign of chronicity, for example, retinal finding, left ventricular hypertrophy, then 1 reading will be enough for diagnosis. Sometimes you are obliged to do ambulatory and home blood pressure readings. These are helpful or indicating the following. When you have borderline cases of hypertension, say 140, 145, and white coat hypertension, when the patient is having high blood pressure checked by doctor, unusually labile blood pressure, shooting up and down, 140 over 80 and next day 160 and so on. And sometimes refractory hypertension. These are people when you give drug, it is difficult to treat, and the other is symptomatic hypo. Remember that there will be transient increase in blood pressure whenever you have an exercise or the patient have exercise, anxiety, discomfort, and unfamiliar surrounding. These will cause transient elevation of blood pressure, which is called white coat hypertension, especially when checked by a doctor. And it has been found that 20% of such people have a normal blood pressure when recorded by automatic devices. And the risk of cardiovascular disease is less than sustained of hypertension, but even greater than normal. Anyway, what's ambulatory blood pressure? This is a device that the patient holds with himself for 24, sometimes longer, and will give a better profile than a limited number of records. It will correlate more closely with the evidence of target organ damage. But the treatment threshold and target should be adjusted downward, not the same as office, because ambulatory blood pressure readings are lower. The systolic is 12-degree lower and diastolic 7-degree lower than clinic. And you should take the average ambulatory daytime, not 24-hour or night. It's the daytime blood pressure. This is used to guide. And the last is home blood pressure. This is not real value, is not well really evaluated, and it is not recommended for everyone. Anyway, remember that the best treatment is office. Sometimes you are obliged to do ambulatory blood pressure recording. Now we go, after we check the blood pressure. Actually, blood pressure is part of examination. We should have already have a history from the patient, whether he has a family history for cause of complications, family history of hypertension, his lifestyle, does he take salt more, or he drinks alcohol, smoking or alcohol, etc. Risk factors, drugs, etc., for example, contraceptive pill, and look for symptoms of secondary cause like secondary hypertension, pheochromocytoma, it will cause flushing and palpitation, etc., and symptoms of complication. Now, what further examination we'll do, apart from checking blood pressure, we look for complications and causes of secondary hypertension. The first, we look to radiofemoral delay, which is a sign of aortic coarctation of the aorta. You check for the femoral pulse and radial pulse. There will be a delay, but this is in people, young people with secondary hypertension. You palpate the abdomen for an enlarged kidney, for polystygny. You put your stethoscope for renal artery stenosis, and of course the Cushingoid appearance and facies. This will be obvious. Look for any risk factor like central obesity, features of hyperlipidemia, tendinxanthoma, etc. And there are non-specific findings, for example, of complications, of course, left ventricular hypertrophy, apical heave, accentuation of aortic content of second heart sound. The optic fundi might show evidence of generalized change. Optic fundi grades of changes, and you might see atheromas or aortic aneurysm as a feature of complication. Now, one point, we define what's called accelerated or malignant hypertension. This is actually rare. There is acceleration, quick microvascular damage, plus, number one, increase in the wall, necrosis in the walls of the small arteries, fibrinoid necrosis, number one. Number two, intravascular thrombosis. So there is acceleration of the vascular change in this. How we diagnose? Evidence of high blood pressure, plus, be careful. Most of our people with isolated high blood pressure are not malignant or accelerated. To define malignant or accelerated hypertension, you should have a high blood pressure plus features of rapidly progressive organ damage. For example, retinopathy grade 3 or 4, you immediately do fundoscopy to see this. Or renal dysfunction, blood urea is rising, or proteinuria is increasing, or hypertensive encephalopathy. neurological features with papilledema. You might have left ventricular failure. I will stress this important point. This is malignant or accelerated hypertension where you have microvascular damage with high blood pressure. This is an indication to lower blood pressure quickly. Otherwise, it is very dangerous and it's not advised to lower the blood pressure if there is no other features. An isolated high blood pressure is not malignant hypertension and is not an indication to lower the blood pressure quickly. If you have all this, then there is an indication to lower quickly. Otherwise, death can occur within months. To summarize the complications of hypertension, high blood pressure chronically will cause cardiac, cerebral, and renal complications. The cardiac is angina, myocardial infarction, heart failure. Cerebral is CVA, cerebral infarction, and TIA, and renal failure. Acutely, it can cause malignant hypertension with microvascular damage. Now, what investigation we should perform for a patient with hypertension? There is a saying in all literature, all patients with hypertension should undergo a limited number of investigation because this is a clinical diagnosis. If you have a perfect clinical technique, then this is enough to diagnose hypertension, but you will go to additional investigation in selected patients or looking for complications. Urine analysis for protein and glucose, proteinuria and diabetes, blood urea for renal function and electrolyte, blood glucose if he's diabetic, serum cholesterol for risk factor, and the ECG to detect any coronary artery disease or left ventricular hypertrophy. Even though we can arrange also for chest x-ray when we suspect heart failure or coarctation, ambulatory blood pressure recording in borderline or white coat hypertension, echocardiogram for left ventricular hypertrophy, and renal ultrasound for polycystic kidney and renal disease. We can arrange also for all these, but there are further sophisticated investigations in selected patients only. Renal angiography when you suspect renal artery stenosis, urinary catecholamines when we suspect pheochromocytoma, and urinary cortisol and dexamethasone suppression test for Cushing syndrome, and plasma renin activity for primary aldosteronism. These are for selected cases. NYs, for example, if you have a patient 60 years old with hypertension and you arrange for urinary catecholamine to exclude pheochromocytoma. Now the last and the most important point in hypertension, the most difficult actually, is management. The management is a stepwise management. It is not just a matter of prescribing drugs or medications. And this is the most difficult issue. Most people think that drugs are given as a mathematical equation, 1 + 1 = 2. You can give hypertension that drug which is good for that patient, etc. And most of our people, by the way, think that a drug from abroad or is good for that patient, so I can use it. This is one. And by the way, you should follow the update and guidelines in the management because these are changing every now and then, every year. The first step is quantification of cardiovascular risk. Is my patient having cardiovascular risk? If yes, then I should consider treatment seriously. If no, then there's another issue. The other, what threshold for intervention? Sometimes in a blood pressure of 150, I will not give treatment in a female, young, having nothing, no risk factor. But a blood pressure of 150 in a smoker diabetic, I would interfere. This is intervention. Then the third question, what target I should reach? Shall I reduce the blood pressure to all of my patients to 130/80 or not? The fourth, what treatment I should use? We have non-drug therapy and we have drug therapy, antihypertensive. Remember this triangle? The antihypertensive drugs are 3 groups actually. The first group is the diuretic, which handle the blood volume to start with. The second are those that handle the heart contractility or sympatholytic or beta blockers, and the third are the vasodilators, and there are several mechanisms for vasodilatation. Sorry. Then, what choice of antihypertensive drug? This is another issue. You can't give a drug for every patient. For example, if you patch a patient with heart failure, then the best drug would be angiotensin inhibitor or blocker and or diuretic. But a patient with hypertension and angina, the best drug will be beta blocker. And a patient with asthma, you cannot give beta blocker. This is how you choose your drug. Then the issue of additional drug, aspirin and antilipid, and I will discuss that. And lastly, there are special situation, emergency treatment of accelerated hypertension and refractory hypertension. Now I will come one by one for all these steps. Sorry. Let us start with step number 1, and that is quantification of risk factors. If you remember, the first point in my lecture was the objective of antihypertensive therapy is to reduce the incidence of adverse cardiovascular events. Coronary artery cardiovascular is a generic term. Coronary artery disease, stroke, and heart failure. And actually, antihypertensive therapy do reduce the incidence of stroke and to a lesser extent coronary artery disease. So we do have benefit, and the benefit is of two types, relative and absolute. The relative benefit, you have a 30% reduction in stroke and 20% reduction in coronary artery disease in all population, while absolute benefit is greatest in those with highest risk of total number of events prevented. I'll give an example. If we give antihypertensive treatment for 1 year, one stroke will be prevented in 500 people who have mild hypertension who are young. But in elderly, you can prevent one stroke in 200, in half of this number. This is the absolute benefit. Anyway, don't bother yourself about these statistical points. How I will estimate the cardiovascular risk? There should be a formal estimation of absolute cardiovascular risk so that I can decide benefit of treatment against the cost and hazard of the drug. It's not logic to give a patient blood pressure 140 over 80 to subject him to the cost and hazard of side effect, and he's not benefiting from treatment. While if a patient benefits from treatment and smoker and diabetic, then you will consider the cost and hazard, but you will give treatment. There are a variety of risks algorithms, but remember that the mortality and morbidity of hypertension is related to coronary artery disease. Don't confuse this term coronary artery disease from cardiovascular. Cardiovascular is a generic term, heart and the blood vessels. Treatment guidelines are based on estimate of 10-year coronary artery disease. I will show that to show my patient within 10 years, he's likely to develop coronary artery disease 10%, 15, 20, 30. From that, I can tell also cardiovascular, CVA and others, by multiplying coronary artery risk, for example, 10 by 4 over 3. If the patient have, after estimation, a coronary artery disease risk of 30%, then the cardiovascular risk is 40. And I'll give you an example. This is from textbook, from your reference. This is cardiovascular risk prediction chart for non-diabetic men. Unfortunately, the diabetic patient has already 20% risk. Regarding the age, sex, smoking habit, blood pressure, cholesterol. Smoking is a lifelong smoking. High density cholesterol will be 1 if you take the total cholesterol ratio. So you have non-smoking, non-diabetic men. This is the non-smoker group, and this is the smoker group. You see the smoker group have more red than the non-smoker. You can apply to any of your relatives. Suppose your father is not smoker and his systolic blood pressure is 160, his cholesterol is 6, and he is not smoker and his age under 50, then he will be in the green zone. His cardio risk is less than 10%. While if your relative, your uncle, age 60, his blood pressure 160, and his cholesterol is high and he's a smoker, then he is in the red zone, more than 20, and it would mean we have the orange zone. So according to that, you can tell which zone my patient is. He high risk, moderate risk, or low risk. A high risk should be offered treatment of blood pressure and other risk factors. Remember, diabetic by itself unfortunately is 20%. This is another chart taking consideration women and men. I'm sorry. This is an example of risk evaluation and treatment. You have a 65-year-old man and again 55-year-old woman, say a man and his wife, with a blood pressure 150 over 90 here, the same blood pressure. But the man is a smoker, the lady is not smoker. The man is diabetic, she is not diabetic. His cholesterol, total cholesterol over high density is 8, this is 6. Previously we mentioned left ventricular hypertrophy, there is no need to mention that. The 10-year risk of myocardial infarction and stroke in this patient is 55%, 56%. Here the 10-year is 5%. So if you lower blood pressure and cholesterol, you will get a benefit from 56 to 25, while here the benefit from 5 to 2. This is actually worthy. You should give treatment. Here the treatment is questionable. Usually most guidelines do not give treatment for this lady. This is number one. Number two, intervention. Which blood level I should intervene? I should consider actually the both systolic and diastolic because both are predictor of cardiovascular risk. I would utilize both of them. Initiate treatment if they exceed a given threshold, 140 over 80, but this threshold is lower, 138 over 88 if my patient is diabetic. If my patient has ischemic heart disease, then the threshold will be lower. I give treatment even 138. While in elderly, the treatment is the same. This is an algorithm which you can read 2 or 3 times, but you will not believe what is written in it. I will go quickly. If you face a patient, this is evaluation of the patient blood pressure in regard with cardiovascular risk. If you check the blood pressure and it is less than 140 over 90, then interestingly, check blood pressure and every 5 years, you tell the patient that you are not hypertensive. Imagine the patient came with headache and his blood pressure is normal. You will tell him come after 5 years. He will after 5 minutes check his blood pressure again. This is one patient. On the other hand, if your patient is 180 over 110, then you probably offer treatment, even some advocate ambulatory. If in between, then you offer ambulatory blood pressure to make sure. If ambulatory blood pressure confirms hypertension, if low, then you will not give treatment. If 135 over 85, then with risk factors, you will offer treatment. If above 150, you will offer treatment. So to summarize this complex table, 140, less than 140 over 90, tell him come after 5 years, it's not practical. 140 systolic to 179 over diastolic, 190 over 110. See target organ damage and cardiovascular risk. If high, start treatment. If normal, you can wait. But if the blood pressure 180 over 110, more than one session, then you consider treatment. You can go to this table and read it again and again. It is very interesting how you put your patient. Now, what target? The target set is optimum is 139 over 83. Still, I am telling you an important thing. Hypertension, there are studies and trials going on every now and then. The figure is changing. This lecture is given in March 2020. it can change this figure if you have a new studies. It will be lower in diabetic patients. So always apply a new guideline. For example, age less than 80, a clinic blood pressure 140/90 should be. While in age more than 80, the blood target should be 150. You should not lower to less than that because there is something called perfusion pressure. You cannot lower the blood pressure more because you have some ischemia in the circulation. And this is the figure for ambulatory blood pressure. I don't like to confuse you with these figures. You should follow up your patients taking antihypertensive treatment at regular intervals to monitor blood pressure, minimize side effect, and reinforce lifestyle. Actually, this was written in the previous textbook every 3 months, but patients cannot tolerate 3 months. You will check earlier. Now, what treatment we offer for the patient? We have non-drug and drug. Non-drug is lifestyle measure like correcting obesity, reducing alcohol intake or stopping, restricting salt intake, taking regular physical exercise, and increasing consumption of fruit and vegetables. These can all lower blood pressure. They in borderline patients may obviate the need, and established patients reduce the dose, but they are not a replacement therapy. Be careful. They can directly reduce cardiovascular risk. There are other things, as I told, direct cardiovascular is like quitting smoking, eating oily fish, adopting diet. These will produce further risk reduction. In summary, non-drug therapy usually help the cardiovascular risk, and some things like obesity and alcohol are helpful. If you lower them, if you treat them, then you can obviate the need or lower dose of antihypertensive drug. Now, the last and the longest subject and most difficult is antihypertensive drug. Antihypertensive drugs are of 3 groups: vasodilators, diuretics, and sympatholytics or beta blockers, those that affect the heart contractility. Back to simple physiology, this is the ventricle that pushes this blood to the aorta. To lower the blood pressure, either handle this fluid by diuretic or handle this, decrease the contractility by beta blockers, or the peripheral resistance, the diameter or the blood vessel by vasodilators. So you have 3 groups of drugs, and the vasodilators have subgroups as well. The antihypertensive drug again are diuretic, vasodilators, and beta blockers. Remember the normal physiology of blood pressure. I brought this so that you will not lower suddenly the blood pressure in certain cases because you will cut off this water from this area. Be careful. There is a motor pushing blood. If you want to wash your hand or water this area, you need certain piping, and you need a motor system, and you need this amount of water. So normal pressure is necessary to supply, but you can reduce this pressure by decreasing the motor power, the heart, or by modulating the fluid through the kidney or elsewhere, or vasodilators. The vasodilators are calcium channel blockers, angiotensin converting enzyme inhibitors, and alpha blockers. So this is the triangle of antihypertensive drugs. Don't suddenly lower blood pressure. This will be thirsty. What choice of antihypertensive drug? This sentence from reference and textbook, and most people do not like it. There is no important or material difference between the antihypertensive drugs regarding the outcome, the efficacy, the side effect, the quality of life. So all of them almost always equal. There are minor differences. Some people make propaganda for certain drug or not. Actually, there is individualization of drugs. And the choice of antihypertensive therapy is dictated by the age of the patient. For example, the older the patient, then you give calcium channel blockers. Ethnic group is not here. The cost is important. Convenience. A diuretic cannot be given for every people. Response to treatment. Freedom from side effect. Comorbid condition. This is the most important. I will talk about in a minute. For example, a patient having angina, then you should give beta blockers and diuretics for elderly and so on. This is the choice of antihypertensive therapy. So most people ask you, what is the best treatment of antihypertension? The answer, we don't have a best treatment for antihypertension. We have individualization of treatment and considering certain factors. I will give some summary or a bit detail of each of the group of drug, and you can go back to your textbook. Diuretics, this is the normal filtration of the kidney. This is proximal convoluted tubule, Henle loop, and then the transverse and descending, etc. You have three groups of diuretics: the high efficacy, the moderate efficacy, and the low efficacy. The loop diuretics work here, like furosemide, the moderate efficacy thiazide, and low. Most people think that diuretic damage the kidney. This is not regarding thiazide diuretics. Let me stop here. Just remember an important thing regarding the diuretics. The mechanism of action actually is not known, although it's called diuretic. It may take up to 1 month for maximum effect. Actually, initially they are diuretic, and later on they become a vasodilator through increasing sensitivity of vessel wall to catecholamine. Anyway, this is theoretical. An example is bendroflu, methazide or cyclopentazide. This is the dosage formulation. You should know this dosage. The other is loop diuretic. These are the loop diuretic are potent diuretic, furosemide and bumetanide. They have few advantages over thiazide diuretic in treatment unless you have substantial renal impairment. In renal impairment, better to use loop if you are obliged, and in conjunction with ACE inhibitors. It's all about diuretic. You can read the detail. The other and the most important are the vasodilators. This is the blood vessel. The vascular tone, or the smooth muscle, is under control of endogenous and exogenous factors. The endogenous factors, the vasoconstrictors, are noradrenaline, angiotensin II, and endothelin. These are endogenous factors that constrict the blood vessel, and you have nitrous oxide, bradykinin, prostaglandin, etc. And you have constrictors to the nerve alpha receptor, and the dilator is the beta, and the calcium ion. Anyway, we'll not go to detail. The first group is angiotensin converting enzyme inhibitor. Physiologically, renin is enzyme produced by the kidney in response to adrenergic beta-1 activity and sodium depletion. Renin converts angiotensin gene into angiotensin 1 and this one into angiotensin 2. This is angiotensin gene, angiotensin 1 to angiotensin 2. And it has two receptors, AT1 and AT2. Remember this because there is something about this nowadays. Angiotensin converting enzyme inhibitors inhibit the conversion of angiotensin 1 to 2. They are well tolerated. Examples are enalapril, 20 mg, ramipril, and lisinopril. Their side effect actually sometimes we should have a care in impaired renal function or renal artery stenosis, and sometimes they cause first dose hypotension. If the patient is intolerant to angiotensin converting enzyme inhibitor, developing cough or angioneurotic edema, then you can use the angiotensin receptor blockers. These are the block angiotensin 2 receptor blockers, have similar effect. Example, losartan and valsartan. These will end in an, losartan, and this IRIL, enalapril. I will tell you one important thing. Medicine is changing every now and then, and research are going on. I will advise all of you to follow the newest research, but be careful of some of them. Now we are living the days of Corona. There's a pandemic over the world of coronavirus infection, and everybody is at home, and even the health authorities in Iraq announced curfew. But so that in these nowadays where there's the fear of corona, a study came out telling that the A2 receptor, actually the enzyme is present in the lung. See, this enzyme is in the lung. The A2 receptor is somewhat involved in increasing the liability to coronavirus infection, which infects the lung. This was a bomb blast nowadays before 3 to 4 days, that because they found the mortality increase in people with diabetes and hypertension, and later they found were those people who was receiving angiotensin enzyme inhibitor or angiotensin receptor blockers. This is what science tells us, and there is a nice explanation. But anyway, before 2 days, another announcement came about safety of this drug. Anyway, this is just to tell you that medicine is changing every now and then. A drug which is useful nowadays might not be useful later on. The other group is calcium channel blockers. You have two chemical groups, dihydropyridine, which is amlodipine, and nifedipine. These are long-acting, cause flushing, palpitation, and fluid retention. And the non-dihydropyridine calcium channel blockers, diltiazem and verapamil, they are useful when hypertension coexists with angina, but they do cause bradycardia and constipation. And I will tell you what's calcium channel blockers. This is the cell membrane where calcium enters. It has two main areas: the conduction system of the heart, the SA node, the AV node. So when they block this, they are used for arrhythmias. The other calcium is in the smooth muscle of the arteries. Okay, it will relax. When you block the entry, you will relax the muscle, it will cause vasodilatation. So the calcium channel antagonist, the dihydropyridine, amlodipine, and nifedipine are smooth muscle relaxant, and they are line number 1 for hypertension among calcium channel blockers. The non-dihydrodipine are like verapamil, acts mainly on the SA node. The diltiazem holds both the vasodilator and the antiarrhythmic. They are best used in angina or in arrhythmias with hypertension. These are the three groups of antihypertensive treatment. And this is the calcium channel blockers. Again, those that act on the SA node, the verapamil, those have negative inotropic effect, and those that affect the smooth muscle of the artery, they are vasodilators, calcium channel blockers like amlodipine and nifedipine. So you have two groups of drugs, and in between the common one is the amlodipine has 3+ vasodilatation. The verapamil has only antiarrhythmic effect, no vasodilatation. Diltiazem has in between, both two. The other group of drug, beta adrenoceptor antagonist. This is the heart, which receives the sympathetic and parasympathetic nerve. The sympathetic stimulate and the para, bradycardia, etc. If you block this receptor here, you can have a decreased heart rate and decreased contractility. This drug, the beta blockers, were the first line of drugs in the 90s, but now it is not the first line of drug. This is how medicine is changing. But it is if the patient is having angina, then you can give the beta blockers. There are many groups, but you should choose the cardioselective that block selectively the beta-1, because you have beta-2 in the lung also. Examples are metoprolol, atenolol, and bisoprolol. So beta blockers decrease contractility of the heart. They are useful, especially when the patient is having angina, and you try to use selective beta blockers. These block the sympathetic nerve, adrenergic nerve to the heart. When the sympathetic nerve to the heart is beta, and the sympathetic nerve to the blood vessel is alpha. If you block the alpha, then you have a vasodilator. Alpha adrenoreceptor, alpha blocker are vasodilator through the nerve. This alpha is present in many areas in the eyes, and remember, in the bladder and elsewhere. Remember this point? This is the autonomic cardiovascular control. You have alpha and beta, as I told you, the beta contractility of the heart, and the alpha is blood vessel. Beta blockers for decreasing contractility and alpha blockers for vasodilatation. Example, prazosin, endoramine, and doxazocine. These actually, they cause postural hypotension. They are very useful drug when you have prostatic hypertrophy. So they are drug. So that's how we choose antihypertensive. If your patient have prostatic hypertrophy, the one who have frequency dribbling, etc., you cannot give diuretic. You perpetuate his condition. So here you will give adrenoreceptor blockers, alpha blocker. Sometimes you use combined alpha and beta blockers like labetalol and carvedilol, especially useful for malignant hypertension. Other drugs are rare. They're acting mainly on smooth muscle directly, like hydralazine and minoxidil. And we have centrally acting drug. I am mentioning these because methyl dopa is the drug, one of the safest drugs used in hypertension in pregnancy. The so-called false transmitter alpha methyl dopa. It is a safe drug, can be used in pregnancy. And you have clonidine. This is a confusing drug. It is alpha 1 agonist. Alpha 2 agonist, sorry. This is a bit a confusing one. This alpha anyway. In this, you have the alpha receptor central and peripheral. Just remember, this is a central blocker. Methyl dopa is safest in pregnancy. Now, when we choose antihypertensive, there are certain things that influence our choice of treatment. The condition of the patient and the comorbidity. This table is from your textbook. I modified a bit. Compelling means you must give the drug. Compelling indication, possible indication, cautious, and contraindications. If the patient has benign prostatic hypertrophy, then this is a compelling indication. But the patient, for alpha blockers, if you have heart failure, then this is possible. You should be cautious for postural hypotension. But if the patient has urinary incontinence, it's almost contraindicated. Regarding beta blockers, myocardial infarction is compelling. Heart failure, not stage 1 or 2. Because in congestive heart failure, actually it's contraindicated. Possible indication, heart failure. Peripheral vascular disease, it's not. And there is almost contraindication, it's not cautious in diabetes mellitus, asthma, and chronic obstructive lung disease and heart block. Another group, angiotensin converting enzyme inhibitors in heart failure, if you remember remodeling, left ventricular dysfunction, post-myocardial infarction, established coronary artery disease, type 1 diabetic nephropathy. It has been found that angiotensin converting enzyme inhibitors protect the kidney in a diabetic patient, and secondary stroke prevention. These are compelling indication. If you have heart failure, then this is number 1. Hypertension with heart failure, hypertension with left ventricular dysfunction, etc. Possible chronic renal disease, type 2 diabetes. Renal impairment is a contraindication, a relative contraindication. Pregnancy is absolute contraindication. Receptor blocker, almost the same. There's a strange difference. This is type 1 diabetic nephropathy, and this is type 2 diabetic nephropathy. Almost the same. Pregnancy contraindication. Calcium channel blockers. The dihydropyridine, amlodipine, and nifedipine in the elderly compelling, and in systolic hypertension. In angina possible, they have no complete contraindication. In diltiazem can be given in angina and in the elderly. Thiazide, as I told you, just in gout is contraindication to rise Otherwise, in elderly patient, isolated systolic, heart failure, stroke prevention, they are one of the best drugs. Now, last few points, emergency treatment of accelerated or malignant hypertension. Be careful, as I told you, it's unwise to lower the blood pressure too quickly because you will compromise tissue perfusion. There is something called altered tissue autoregulation. The body tries itself to modulate the blood flow. If you lower suddenly, there will be altered autoregulation already is there. If you lower, then you might get cerebral damage, including occipital blindness and coronary artery insufficiency. Why? Because the coronary artery already narrow in some people. If you suddenly lower the blood pressure, it depends on a perfusion pressure diastolic, say 90. If you lower to 80, then you will not have a good coronary perfusion. And this is a strange thing in your textbook. Read it for 10 times and you cannot believe it. Even in the presence of cardiac failure or hypertensive encephalopathy, a controlled reduction to a level of 150 over 90, not to 130, over a period, although this is an exaggeration of 24 hours, in a matter of hours, it's equal, and you can avoid parenteral. Unfortunately, what happens when we find people high blood pressure, you give immediately radical treatment to lower. This I told you, lower if you have accelerated or malignant. By accelerated or malignant, we mean we have papilledema or renal impairment. You can give intravenous or intramuscular labetalol, intravenous glyceryl trinitrate, hydralazine, which is again safe in pregnancy, by the way, and sodium nitroprusside. So the lesson from this, in accelerated or malignant, okay, lower it quickly. Otherwise, there is no point to lower the blood pressure rapidly. Remember the pump and the water. Combination therapy is sometimes advisable. You can go to this algorithm, step 1, step 2, step 3, step 4. If you fail, people above this age, below this age, which drug you choose. The combination therapy actually have fewer unwanted side effect, and some have synergistic effect. And there is something called refractory hypertension. You give treatment, the patient comes to you and then tells you that he might have genuine resistance to therapy, non-adherence, is not taking the drug properly, failure to recognize an underlying cause, for example. And nowadays I can tell another thing, the drug is not working. In this case, you can add spironolactone, which is mineralocorticoid receptor antagonist, is useful. The last point probably, most of our patients ask you, I am hypertensive, shall I take aspirin or salicylic acid or statin? Aspirin is a good drug for reducing cardiovascular risk, but remember, it causes bleeding, and in hypertensive patient, it might cause intracerebral hemorrhage. So you should have the benefit that outweighs the therapy. When you have benefit from aspirin, if you have your patient aged 50 and over, and the blood pressure is well controlled, not a very high blood pressure, and either target organ damage or diabetes or 10-year mortal cardiovascular risk more than 15. Say, the patient is diabetic, okay, give him aspirin. If the patient, you estimate his 10-year cardiovascular risk more than 15, give him aspirin. If you have left ventricular hypertrophy, okay. Otherwise, if you give aspirin, then you might have a patient with intracerebral hemorrhage. The other statin, antilipid, treating hyperlipidemia, will have substantial reduction in cardiovascular risk. Is indicated in patients who have established vascular disease. For example, whether he is hyperlipidemic or not. A patient with ischemic heart disease, you should give lipid-lowering agents even if his blood lipid is normal. And the second issue, if you have hypertension with high risk of developing coronary artery disease, 10 in 10-year diabetic patient, for example. Thank you very much. This is all about hypertension. The second part of the lecture is a continuation of the first. If any question or query, you can ask. And thank you very much for your listening. See you in exam.